So, a very good evening to all of you. I am Dr. Abhijit Kumar from Zydus Healthcare Limited. And first of all, I would like to welcome you all in this academic session on bempedoic acid in uncontrolled LDLC, unlocking concept and unleash efficacy. So, for this, we have our reputed speaker, Dr. Y. Vijay Chandra Reddy sir. He is MD, DM, MRCP, FS, CCFCSI, CCBS, is a senior consultant and interventional cardiologist at Apollo Main Hospitals, Chennai. He is a well-known in field of interventional cardiology with extensive and versatile experience in range of professional work. He is a pioneer in transradial interventions and complex high-risk chip interventions. Also, he is versatile in coronary imaging, implantable cardiac device therapies, thoracic and abdominal aortic endovascular stent grafting. He is a key opinion leader in cardiology with special interest in teaching, training, and mentoring young cardiologists. He's with a proud academic career studded with multiple gold medals. He also has been a recipient of several awards like the Outstanding Research Award, the Best Donor Award, the Best Doctor Award, Tampa Professional Excellence Award, Technical Innovation Award, Best Interventional Cardiologist 2017, and Medical Stalwart in Cardiology in Tamil Nadu. So with this, I would again like to welcome Dr. YVC Reddy sir on board. So welcome sir, and I would request you to take over the academic session from now.
Thank you, Abhijit. Wonderful evening, and welcome everyone on board to this interesting talk on the new, much anticipated and awaited anti-lipidemic molecule, bempedoic acid. We have been in the field of atherosclerosis and lipids for almost 3 decades, but we should know from the history that only about 220 years ago, someone first thought that the entire episodes of sudden syncope and death, chest pain and death, were all due to the coronary artery plaque ruptures. It was only as nascent and as young as 220 years or so. Then slowly the reason why this was happening was not known. And then probably in the last 5 decades, some research has opened up this area of dyslipidemia being one of the important risk factors for this disease. And of course, once Goldstein and Brown started their pioneering work on cholesterol, everything became, you can see now?
No, sir, not yet.
Yeah, I'm just opening the screen. Yeah, you can.
Yes, sir, it is.
Yes, yeah. So then came tremendous rapid strides and advances in this field of atherosclerosis and understanding of not only about the lipids and how they come into the picture, and also about the reverse cholesterol transport and how to modulate these mechanisms for our advantage in reducing the LDL cholesterol. So this is a very, very much anticipated welcome drug in the scenario where several of our patients who needed statins in a big doses were not able to tolerate either even a mild dose or unable to increase the doses to the reasonable target levels. So we all know that dyslipidemia, there is no doubt at all that this is probably the most important reversible, modifiable risk factor for atherosclerosis. If you see this is the intra-heart study. For those who come with the first heart attack, 5 continents, 52 countries, the same story. All the reasons could be boiled down to these 9 risk factors, of which the predominant one is the lipids. We call it the population attributable risk. 90% of the first heart attacks in so-called healthy people before, you could point out that they will have one of these 9. In that, as I said, if top of the list is not diabetes, top of the list is not smoking, top of the list is not hypertension, top of the list is lipids. So this is a very, very important point to understand. So we must be seeing lots of patients with dyslipidemias in the master health checkups. And if you don't give enough importance to it, then we will be doing a disfavor in preventing the atherosclerotic cardiovascular disease. So this is a biggest lesson from the intra-heart study. Okay, now you see about the primary prevention trials. This is about those who have come with an MI, an atherosclerotic event, But what about those primary prevention where someone has high lipids, dyslipidemias, but then if you use statins in these people, does it really benefit? Are we able to get any reduction in myocardial infarctions, unstable angina, sudden deaths, the need for revascularization, strokes? These are all the major adverse cardiovascular and cerebrovascular events, the MAXI. These are the ones we want. And if we use statins, we know that so many trials in the primary prevention, including the latest ones like the Jupiter, from the old ones like the AFCAPS, we know that 25 to almost 50% reduction in these endpoints are there. So it's a very, very useful drug. Statins are able to achieve this, not only a reduction in the lab value of the LDL cholesterol and other lipid levels, but also a MACE conversion is there. There's an excellent hard endpoint reduction in the primary prevention arena. In the secondary prevention arena, of course, we all know that it's well accepted that they are the drug of choice in achieving this goal. The benefits are not just due to LDL cholesterol reduction, but so many other beyond that. Some pleiotropic effects will be there as well. And all the statins we are well aware. And the reduction in LDL is in the range of 25 to 35% or so. But the benefits, again, like in the primary prevention arena, you get tremendous reductions in mortality, revascularization, stroke, and unstable anginas. So the same story. So if you achieve LDL cholesterol reduction with statins, it is converting into hard point and endpoint reduction as well. But there are two major stumbling blocks along this path. One is, do all statin users achieve the cholesterol goal as per guideline recommendations? Are we able to, do they achieve it even if you use the biggest dose? That is one. And secondly, how is the safety issue? So one is the efficacy, another is the safety. Is it, are they able to achieve the doses which are normally said to be the maximum doses that can be given to the patient? So in terms of efficacy, are they good enough? In terms of safety, are they safe enough? These are the two stumbling blocks, and day in and day out, we all of us use statins in a big way, and we find both of them to be a real concerns on the real world arena. Coming first to the efficacy part, we know that if we use statins compared to all of the drugs, we do achieve a good amount of LDL cholesterol reduction, as you said, 25 to 40% or so. By definition, we say any LDL cholesterol reduction of about 50% from what you started with is called a high intensity statin dose. Those which achieve only about, say, 30%, we call it a moderate intensity. In the current times, we use only rosuvastatin and atorvastatin, and to a minor extent, probably the other statins are used. But these are the two predominant statins, and the high intensity statin in this way would be rosuvastatin 20 or 40 and atorvastatin 40 or 80. Rest of it is moderate intensity statins. So what do they do once they achieve this? What you can see that here, the relative risk reduction of diseases we have discussed there. But then if you use something else to add on to this LDL cholesterol reduction, it is adding to even more relative risk reduction. So there is something you can achieve beyond statins. The best evidence came from PCSK9 inhibitor trials, and you found that there was a 50% reduction of events there. Tremendous increase over and above statin usage. If you use something more potent or by a different mechanism, you will get more benefits. As a general rule, about 38 milligram per deciliter reduction in LDL cholesterol, you will achieve a 23% relative risk reduction in the MACE events. A big thing. So the hypothesis is proven here. Beyond the statin usage, you can achieve some more LDL cholesterol reduction, which will convert into endpoint reduction as well. How we achieve this? Of course, PCSK9 inhibitors is one pathway, one step you can take. But then this is a very expensive, and in the real world, in our country, we're not able to use it much often. We have, of course, ezetimibe, which is available. It is not as potent as statins, but we should understand that it acts in a different pathway. This interferes with the cholesterol biosynthesis. So there is a more LDL receptor expression on the hepatocytes and more clearance of LDL cholesterol from the bloodstream. Ezetimibe interferes with cholesterol absorption, a different pathway altogether. Again, we know that cholesterol absorption does not mean the cholesterol taken in the diet. That is very, very marginal in most of the populations. The enterohepatic circulation of whatever LDL cholesterol issues, they come up from the biliary tract into the gut. They are always reabsorbed. there it helps. So even in a zero cholesterol diet, ezetimibe will definitely have a role in reducing the LDL cholesterol level. So this is one additional stream of action: cholesterol biosynthesis inhibition, cholesterol absorption inhibition. And here is a totally different pathway. Here what we are doing is, we know that when you use statins, LDL receptor expression on the hepatocytes is more. That is how the efficacy is there. But body has got a mechanism whereby it can make these LDL receptors defunct. That is through the PCSK9. So if you can interfere with the PCSK9 again through a different mechanism, then we can see that, or we can get some more benefits. So there are three different mechanisms of action of this LDL anti-lipidemic drugs. PCSK9, of course, we have monoclonal antibodies, the evolocumabs and the qmabs. And you also have got the new inclisiran, which is a modified mRNA synthesis inhibitor itself. So this is the issue. As the cardiovascular risk increases, we need to reduce more LDL cholesterol. So in our general population, who we come across, we do come across all sorts of these patients. Many of our patients are in the high risk and very high risk group. For example, we'll go back, let us recollect. Who are the lower risk groups? They're the general population without any atherosclerosis, only LDL cholesterol level, just maybe a couple of risk factors. You want the target to be less than 115. We know that in the current evidence, the target levels have been made more stringent. Those with a moderate risk or a high risk, you need bigger LDL cholesterol reduction. The target goal for every diabetic, for example, every diabetic should have an LDL cholesterol level should be less than 70 ideally. Every CAD or atherosclerotic patient should have it less than 70. And those with high risk features, high risk means a diabetic or a CKD with atherosclerosis, or if heterozygous familial hypercholesterolemia, or any CAD or atherosclerotic disease who have undergone a revascularization procedure, they all, we have to get it down to less than 55. This is the current standard. Of course, there will be people who continue to have recurrent ACS events despite good control. There, we can call it the extreme high risk group, where we want it below 40 also. That is a target which is coming up, including from the Lipid Association of India guidelines and the US Endocrinological Society guidelines. So at least in our general routine patients, like the usual diabetics without ASCVD, less than 70, those with proven atherosclerosis, less than 55. They are basic targets. But are we able to achieve these targets with whatever statins we have and with the dosages the patients are able to take and tolerate? So this is a nice cross-sectional observational study done in European Union. The Da Vinci study, what they've done is, they've seen the lipid lowering drug prescriptions in the primary and secondary prevention arena. 18 countries. Usually they follow the guidelines well in Europe, and this is what is seen. If you apply the 2019 guidelines and see how many patients are receiving appropriate statin doses, of course, here if you see low intensity, moderate, high intensity, we said most of the time we'll be using either a moderate or high intensity statin, these two. And this is the average overall. What you find is the proportion of patients receiving these drugs, high intensity statin is only about 1/4 only are receiving it. The majority are receiving only, half of them are receiving only moderate. High intensity was only 1/4. Why is it? Either it is physician inertia or the patients cannot tolerate. And probably the patient tolerance is a big factor. In countries where financial constraints in prescriptions are not there, the uptake from that angle is not there at all. And the guideline following also is quite strict and adherent there. So this probably is intolerance is being reflected in this reality. And even if you use that, is it converting into achieving the target goal? No. If you see that even in the high intensity statin group, the proportion of patients achieving goal is not great. Maybe about you are getting 30% to less than 50% are achieving the goal. This is the harsh reality of statin usage. Same thing in, that was the, you take to the high risk atherosclerotic cardiovascular disease or cerebrovascular disease patients. So these are the patients we see routinely, CAD, MI, undergoing PTCA or undergone CABGs, and we know that they need to be controlled very well. Even in this group, if we use the new guidelines, we want less than 55 target for high intensity statin. Still, only less than 40% were able to take that much. And the goal achieved was abysmally low. So the two stumbling blocks with statin therapies, the ability to push the patients on to the full acceptable dose, say for example, rosuvastatin 40 and atorvastatin 80, is not possible in the majority of patients as a reality. From Europe, the Da Vinci has clearly shown that. And even if you do that, the ability to achieve the target goal is abysmally low as well. So this is the harsh reality. These are wonderful drugs. Statins are wonderful drugs, and every patient, the indicated patient, should be on a statin, and the dose should be hiked up to as much high a tolerable dose as possible. But then if you meet a ceiling because of the efficacy or the safety issues, then we have to look out for the alternative strategies and add-on therapies. Otherwise, the residual risk, 70%, these patients continue to have a residual risk, and they will be coming back with events, which is not a nice thing to know. So this is it. So what else can we do? As we said, high intensity statins, you can achieve that. All of us, we know that the rough rule of six, if you double the dose of statin, 6% additional LDL cholesterol reduction only can be achieved. So there's a rough one, of course, but what it means is you hike up, you might not get great thing. A 20 mg rosuvastatin, you get a good reduction, you make it 40, some additional 6 to 10% reduction can be there. Whereas if we add a totally different line of drug, ezetimibe is a cholesterol absorption inhibitor, suddenly you see a jump. The synergism is quite good. The same with PCSK9 inhibitor, very potent. You add it with a statin, a synergism. And if you add all three, 85% cholesterol LDL reduction. So we know that synergism and additive concepts are very well acting in the statin arena. So now, in this background where the efficacy and safety stumbling blocks are there for these wonderful drugs called statins, this is a wonderful new addition, bempedoic acid. This is a well-awaited, much awaited drug, the first in the class LDL lowering drug, because the HMG-CoA reductase inhibitors, statins, they do act well, but ACL is a step well before even the HMG-CoA. So this bempedoic acid inhibits the cholesterol synthesis in the upstream before even the HMG-CoA pathway. So that is a difference from how it acts there. There's one more important difference between bempedoic acid and statins. We'll come up to that in the next slides. But the action-wise, that is a difference. It acts upstream of the pathway. So it has also shown very good benefits. It acts in the biosynthesis inhibition like the statins, but upstream, as we said. And then there will be increased expression of LDL cholesterol receptors on hepatocytes. So more LDL cholesterol is removed from the bloodstream. And that's how you achieve the reductions. And that converts into hard endpoints as well. Approved already in US and European Union for more than 2 years. In India, approved about 2 months back. So the indication is quite clear. If you have used the maximum tolerated statin dose and the patient cannot take any more, but still, or you achieved the high ceiling, say 40 statin of Rosua or 80 of atorvastatin, but still the LDL cholesterol levels are 80s or 70s or 90s, definitely you can think of adding bempedoic acid. The other indication, those like a familial hypercholesterolemia. We do have lots of heterozygous familial cholesterolemia among our population, mixed dyslipidemias, and those with high risk of ASCVD, where you want the LDL cholesterol to be less than 55. That is also a good area where statin is not able to do the efficacy job. Add on to that. The other group is the statin intolerance. You can't increase the dose. A patient has muscle pains or liver problems, or they're totally, absolutely, they cannot take because of myalgias or myositis. Then this is a wonderful drug which will help in that scenario. It's a very easy drug to take, 180 milligram orally with or without food, once a day, one shot once a day. Tolerance is not a problem. The patient's complaints is not an issue at all. This slide again shows that where statins act on the HMG-CoA reductase here in the biosynthetic pathway, this acts on a step upstream on the ATP citrate lyase level. The another difference in the way these drugs act, or the statins are compared to statins, this is a bempedoic acid is a prodrug. So prodrugs, as you know, need something inside the human body, some enzyme to activate the drug into the active molecule, which only will start working. then that reduces the cholesterol synthesis. So this activation of bempedoic acid, which is a prodrug, into the bempedoyl CoA, which is an active drug, is possible in many tissues, but not possible in skeletal muscle, because skeletal muscle does not have this activating enzyme. This is where the entire beauty of this molecule lies. Because this activation of bempedoic acid is not possible inside skeletal muscle, it cannot act on that pathway inside the skeletal muscle, and the side effects also are almost minimized. All the statin side effects on muscle are minimized with bempedoic acid. So are there any uh, concerns with dosage modifications in liver and hepatic and renal patients? In this slide, that's what we're focusing on. Once a day, half-life 21 hours. Majority of the drug is excreted through kidney, 5% through feces, and less than 2% is unchanged drug excretion through kidney. So what you can see here, majority is through the kidney. Drugs which are excreted through the liver, excreted in the sense either excreted or which are catabolized in the liver, like statins, they need the cytochromes. They do catabolize the drugs, and then that is how the drugs are removed. Whereas this is mainly through the kidney. The once your drugs are acting through the cytochrome, they are getting metabolized like the statins. You are more prone for drug interactions. That is where the problem with statins lies. Tremendous drug interactions. So the renal impairment patients, what is the dose adjustment? In the usual patients, no need to change the dose. Of course, in end-stage renal disease, the data is not there. In hepatic, the same issue. In the usual hepatic, moderate, mild diseases, no issue of dose adjustment. Extremes like class C, child pukes, not known data. So except in those areas, you don't need dose adjustments for this drug. The two concerns are there might be a slight increase in uric acid and creatinine in some patients. 1% or 2% of patients can have a slight increase in uric acid level, and 1% can have a gout increase as well, a precipitation of gout. Extremely rare, but it is a very easily identifiable problem. You can monitor the uric acid, and if someone already has got a hyperuricemia or gout, probably you can avoid using this drug. This is not an unusual side effect of many of the cardiac drugs. For example, ticagrelor, which we use day in and day out for PCI, for intervention, also has got this similar side effect. Then the other thing is the creatinine. A marginal increase, very little increase of creatinine can happen. Again, this is not an uncommon feature. Many of the drugs we use, ARNIs or ACE inhibitors, ARBs, can increase marginal creatinine as well. And this has no clinical significance, but we can keep a watch on that. So these are the two things to watch about. There has been some red flag for tendon ruptures. We all know that tendon ruptures are common in elderly people who take steroids. We also know that those taking fluoroquinolone, ciprofloxacin, ofloxacin, they are prone for tendon ruptures. In such patients, we always are careful about any drug which can probably add on to the trouble. Here, it is not a known or documented connected side effect of bempedoic acid, but there have been some doubtful associations. We should be careful in watching for this as well, and probably avoid in those patients who are elderly and taking steroids and with renal failure. So the other issue is avoid concomitant use of bempedoic acid with simvastatin and pravastatin in high doses because of drug interactions. Have pregnancy and breastfeeding, of course, like with statins. No major evidences. Unless the benefits outweigh, better not to use there. What about the data? Is there any data here? If you take the cholesterol LDL, the efficacy part, the reduction alone, we have got data in both the subsets of indications. As you said, one indication is patients have taken the maximum possible statin dosage, and then they are not able to take any more, and they have achieved the whatever dose maximality, but the reduction in LDL is not enough. So you are going to add on bempedoic acid and see what happens. These are the two trials, Clear Harmony and Clear Wisdom, and both are a 52-week trial, 1-year trials. The other is the patients where statins cannot be taken at all because of side effects, or only a very small dose they can take and they cannot hike it up at all. Here we can call it as a statin intolerant group. These are the Serenity and Tranquility. 12 and 24 weeks have been studied here. The same indications. Those with multiple risk factors and high LDL cholesterol or heterozygous familial hypercholesterolemia and cholesterol, any atherosclerotic CVD with LDL cholesterol increase. All these are the classical indications, but two different indications on maximum tolerated background statins and on statin intolerant group. And let us see the results. The efficacy, as we said, was seeing how much LDL cholesterol reduction is achieved at 12 weeks in those patients who already are on maximum tolerated statins, and you could see this 15 to 16% additional LDL cholesterol reduction on those who already were taking good amount of statins. If we said roughly the rule of 6, we were saying if you double the dose of statin, 6% additional increase. Here, if you see 16% additional increase is there just by adding bempedoic acid. So this is a good indication clinically. You know that patient is taken this much statin, you can't achieve any more, and you add this, you're straight away getting some 15% LDL cholesterol reduction, which will definitely be helpful in reducing the event rates. What about the statin intolerant or very minimal statin dosage only is possible, 10 milligram of whatever, 5 or 10 of rosuvastatin. Beyond that, they cannot take or they cannot take it at all. What happens when you straight away put them on bempedoic acid, either alone or with ezetimibe combination? Tranquility and Serenity address this issue. Again, at 12 weeks and 24 weeks, if you study there, the reduction is quite good. If you see here, 24% reduction. This is a big number. So we can get a big amount of LDL cholesterol reduction in this scenario as well. And what about combination with ezetimibe? We all have been using statin plus ezetimibe combinations. What about bempedoic acid plus ezetimibe? As a fixed drug, you can use, or you can use separately, whichever. But if you see here, you could see that if you add bempedoic acid, 17% reduction, ezetimibe alone 23, and if you combine synergism 36%. So these drugs, like statins, you can combine with ezetimibe. You can use like statins alone, standalone. So standalone bempedoic acid, standalone ezetimibe, standalone statin, or combinations of any of them. All are possible, and they're all safe synergistically in terms of safety issues. No safety concerns at all. So the much awaited big trial, the global cardiovascular outcome trials with this drug is going to be soon in another 6 months. Enrollment is completed, a big trial, phase 3 clinical trial, 14,000 patients. We are looking for outcome trials. Till now, all the data is about the surrogate marker of LDL cholesterol reduction and the cardiovascular outcomes, reduction in MACE. Is it going to be there? I'm 100% sure that it's going to be there, because till now, whichever drug has achieved LDL cholesterol reduction, even ezetimibe or any other way, we are able to get the similar benefits in outcomes, and this is going to come out at trumps as well. So the American Diabetic Association 2022 also mentions this as a lipid lowering drug with efficacy. So the adverse events, we are highlighted this rare and a small significant increase in uric acid and gout levels. Again, easily can be monitored, and once you stop, very easily reversible. So no major issue here. The liver enzyme elevation, which is a problem with statins, is seen in a small percentage, but it is not significant. This is an advantage over statins. Tendon ruptures, not significant. Diabetic worsening. We all know that statins, there has been a concern. Even though we know that statins increase HbA1c level by a marginal amount, we are not worried about that because the benefits far outweigh the risk. That problem also is not there with bempedoic acid. To summarize, we all know that LDL cholesterol reduction is very important, both in the setting of primary prevention, which is a huge number in among our patients in our country, and in the setting of secondary prevention. And in secondary prevention, we know that statins are the drug of choice. Our job is to increase the dose to the maximum tolerable dose and reassure the patients about the benefits of statins. But once you reach that ceiling in terms of efficacy or safety, we need not be worried about anymore because an alternative drug is available, bempedoic acid. We can use that for both additive effects on statin as well as standalone when statin is absolutely intolerant. And we can also add ezetimibe onto this and get synergistic benefits. So this is a first-in-class agent as well. So the LDL cholesterol reduction, if you ask, as an adjuvant to statin, about 18%, 24%, probably up to 24% standalone, and 36% ezetimibe plus bempedoic acid. And quite safe drug. The two rare side effects are easily identifiable, easily reversible as well. Thank you. And this is an interesting topic, and we can have a detailed interaction and discussion. Over to you, Abhijit.
Thank you, sir. Thank you for this elaborative as well as informative session. So now we'll move on to our next question and answer session. Sir, we have few questions. Should I start now?
Yes, I think so. Yeah.
So, sir, first question is, can it be combined with PCSK9 inhibitor, and what should be the expected results?
See, as of now, we don't have data on that arena. But if you see, I can put it in this way. Cholesterol reduction, LDL cholesterol reduction, there are three streams. Physiologically means the mechanistically, there are three streams. One is you reduce the biosynthesis, the biosynthetic pathway inhibition. One is statin, and this is bempedoic acid. The second is absorption of cholesterol inhibition from the gut. That is the ezetimibe path. The third is PCSK9. You have to either inhibit them by monoclonal antibodies, PCSK9 inhibitors, or reduce the production of PCSK9 itself by using the inclisiran. So in these three different streams, it makes sense to combine these whenever you need. But because PCSK9 stream is such a potent one, the need for additional strategies along that stream probably are not that much. But in these streams, like the statins, you need additional the other stream also because they are not as potent as PCSK9.
So, answer next question is this molecule bempedoic acid being endorsed by any of the guidelines like ESC or ACC?
See, ADA has highlighted that. This is just a question of time because we are just waiting for the cardiovascular outcome trial. As of now, if you want the outcome trial data, of course, you have to wait for that, for it to come into the guidelines. But for cholesterol reduction alone, I think it is a no-brainer. It has always been there. If you want to achieve LDL cholesterol reduction well and over whatever has been achieved with the maximal tolerated dose or intolerant patients, bempedoic acid has been allowed by FDA drug. For that reason, for the last 2 years, if you see the data from US and Europe, the uptake of bempedoic acid has been on the rise in both these continents.
So, sir, again, this question is what we were discussing just before the session. How frequently should we monitor uric acid level in patients whom we prescribe bempedoic acid?
See, there's no hard and fast rule, but it makes sense. For first time when you're using that, maybe you can check it in a month's time or so. You ask the history, the patient has a known gout, or if they have definitive evidence of previous hyperuricemia and they're on medication for that, there maybe you have to keep checking it more often. Otherwise, it is not a big concern.
So, sir, one last question we have, can it be combined with any other statin? Like in the discussion, it was said that it cannot be combined with simvastatin. So, why is it so that we cannot combine?
Most of the trials, when you see the trials where the statins that are used are all atorvastatin and rosuvastatin. Theoretically, you can combine it with any statin, but if the statins are belonging to the group, see, there is something called WOT1 organic anion transport protein. I think many cardiologists, I think if you go deep down into that biochemistry arena, I think it becomes very dry. One should know that most of the drugs, the body tries to catabolize them by uptaking in the hepatocytes and then subjecting them to cytochrome P. That is how the mechanism acts. There's something called the organic anion transport protein, WOT1, P1B1. What it does is it takes up these things into the hepatocytes. Many of these drugs are inhibitors of that. And many of the drugs interfere with cytochrome as well. So imagine if some statin is there, which is dependent on these mechanisms. And if you obstruct the catabolism of that statin, the drug levels of the statin rises manifold. What happened with cerevastatin, you must have been aware. One of the most potent statins released and immediately taken off the market because cerevastatin plus gemfibrozil. Suddenly we found a lot of hepatitis, muscle necrosis, rhabdomyolysis, the same problem. So when you're using bempedoic acid, this is also a OAT inhibitor,
Yes.
OAT P1B1 inhibitor. And some statins which are dependent on these pathways, they accumulate too much. The area under the curves are more, and you are exposing the patients to toxicity of statins. So there's a reason better to use statins which are not that much dependent on these pathways. For that, atorvastatin and rosuvastatin are better. Theoretically, rosuvastatin probably is more hydrophilic and less subject to this conflict vis-a-vis atorvastatin, but very little data on this. Any of these two statins are good enough.
So thank you, sir. With this, we have come to end of our today's session. So first of all, I would like to thank our participants for making this an interactive session, as well as especially to you, sir, that you agreed to impart us knowledge on this molecule at this hour of late evening. Once again, thank you, sir, for your participation in this presentation. Thank you, sir. Good night.
Thank you all. Bye-bye.
Thank you. Sir, thank you, sir.
Thank you, sir. It was a very beautiful presentation.
Thank you. Thank you all. Bye-bye.
Thank you, sir.
Bye, sir. Good night.